Hi everyone, this is a video lecture for newborn. I'm going to be talking about some of the physiological changes that occur when a baby is first born. As I had mentioned in thermoregulation video lecture, respiratory system and cardiovascular system, you can see that it goes through probably two of the biggest changes in transitioning from fetal circulation to our circulation. Next up is the gastrointestinal system. We're going to talk just a few things. One is at birth, the capacity of the newborn stomach is very, very small, about a teaspoon. That stomach volume increases to about 60 milliliters by the end of that first week. Stomach takes about 2 to 4 hours for emptying time. And that's how often you should be feeding the baby, not like every, orders like feed every 2 to 3 hours or feed every 3 to 4 hours. You feed it on demand. The other thing that I want to talk to about is vitamin K. Vitamin K is produced in the gut of babies in us, okay? And that's vital for the control of bleeding. But because the babies are born with their gut being sterile, vitamin K isn't produced, and it takes about a week after feeding has been initiated, and that's why we give that vitamin K shot. Some of the bowel movements that you will see with babies, the first one is called meconium, and is like this black tarry type of stool, and that first stool is sterile. The next type of stool is a transitional stool, and then it contains both the milk stool and the meconium, and it's a little bit lighter. And then the third type of stool is the milk stool, and that's when meconium has gone through the system. And it's basically how a baby feeds, whether it's breastfed baby or a bottle-fed baby. Their stool will look a little bit different. Now, if they're breastfeeding, it's more like a yellow seedy. Breast milk has like this natural laxative. So babies tend not to be as constipated as those who are bottle fed. That contains iron. So though that's that. Now we'll talk in class about the advantages and disadvantages of breastfeeding and bottle feeding. But one of the things I want you to make sure that you come to class knowing about what is the function of prolactin and oxytocin. All right. The other thing we're going to talk about is what system's next? The urinary system. Okay. So newborns lose about 5 to 10% of their weight in the first week due to diuresis, defecation, respiration, and really dehydration due to limited fluid intake because they don't really know what they're doing at this point. Weight usually comes back within a couple weeks, sometimes a little bit more quicker with bottle feeders just because that instant gratification is right there. So the formula is fed and they are getting the right fluid, whereas breastfeeding takes a little bit longer to establish. Sometimes, because there's a little bit of urine left in the bladder, babies will urinate at birth. In those first couple days, they'll urinate like maybe 2 to 6 times a day, but it should increase by 6 to 8 to 6 to 10 diapers in a week. And that is how you know a baby is getting enough, is if they're voiding at least 6 to 10 times a day. Now, their urine is pale and yellow in color, less concentrated, has a lower specific gravity than ours. It's odorless, and sometimes it's very difficult to tell if a diaper is wet against a white diaper. However, those blue lines have helped us tremendously. You may see little bit pieces of like red brick dust. Those are uric acid crystals, and those are normal in the beginning. The next thing we're going to be talking about is the hepatic system. There's 5 things that we're going to be talking about. Gluconeogenesis, which has to do with the production of new glucose that occurs in this new liver due to consumption. So as the baby eats, it's going to start producing more and more glucose. Prior to birth, maternal glucose is the one that passed through the placenta, but insulin did not. So the baby's pancreas would produce the insulin before birth and will continue to do so after birth, but the only thing is that without mom's glucose. So baby isn't getting that glucose from mom right away. So it bottoms out about 30 to 90 minutes maybe after delivery. But because of this gluconeogenesis, the levels start to rise. Now, if you're a baby of a diabetic mom, that's a little bit more risk, and there's a little bit more to it than that. And we'll talk about that later in the semester. Physiological jaundice is common in most newborns and even more common in premature babies. It usually resolves without treatment. It's the yellowing of the skin and the sclera, and that's where it usually starts. And as it moves downward, it's a little bit more serious. It's caused by a rise in unconjugated bilirubin. Bilirubin defined is the breakdown of red blood cells. So the bilirubin is normally conjugated or joined in the liver. This conjugated form can be excreted. So when not enough bilirubin is excreted, jaundice occurs. So why babies have a large number of unconjugated bilirubin is because of the high volume of red blood cells at birth. Now, we're doing a lot more delayed cord clamping. Sometimes they're milking the cord and putting all of that volume back in, which increases the RBCs, and then they have to break it down, and the immature liver can't do all of that right away. Also, the short life of RBCs, and again, we talked about the immature liver. Now, there's a breastfeeding associated jaundice that has to do with ineffective feeding. Colostrum works as a laxative, as I had mentioned. So if there's less colostrum consumed, that means the stools are not happening, and that means that unconjugated bilirubin stays around a little bit longer. Now, pathological jaundice is something that we're going to be talking about in a minute, but I want to talk about iron storage first. Iron is found in both breast milk and formula, and also the baby produces its own iron at birth that will last about 4 to 6 months. The American Academy of Pediatrics is recommending that all babies, regardless of how they're being fed, get an iron supplement. Now, pathological jaundice is in your higher risk chapters, and your book discusses many reasons. We're going to talk about one, and that is the RH incompatibility. Okay, it is the most severe form of jaundice that occurs within the first 24 hours, whereas the physiological jaundice that I had just mentioned happens after 24 hours. So timing is very important too. If it's severe enough, you're going to know right at birth. And this is with an Rh negative mother only. And the goal is to prevent kernicterus, which is brain staining, which causes severe neurologic impairment and even death. Now, what is Rh incompatibility? So if I'm B positive, do I have a chance of getting this pathological jaundice? No, you do not. If I have O positive, AB positive, B positive, A positive, I do not have any chance of getting this pathological jaundice. However, if my blood type is Rh negative, A negative, O negative, AB negative, A negative, B negative, any other negative that you can think of, the risk is real, okay? And what this is that there is Rh incompatibility. So basically, it is the passage of antibodies across the placenta that destroys the red blood cells of the fetus. So there is a shot called RhoGAM, and a RhoGAM is given at a couple times during the pregnancy. The first time is at about 28 weeks pregnant. And what that does, it prevents the rest of the pregnancy, and it prevents those antibodies from going in and destroying those RBCs. Okay? Now, everything's great. Okay? Now, mom delivers her baby. We send the cord blood, and we check to see if the baby is Rh positive or Rh negative. If the baby is Rh negative, we're done. Okay? If the baby is Rh positive, mom is going to need another RhoGAM shot within 72 hours after delivery. And this is to protect the next pregnancy up until she's 28 weeks pregnant, where she'll get another shot of RhoGAM. Okay? So, again, at 28 weeks, a mom gets a shot of RhoGAM if she's Rh negative to prevent the remainder of the pregnancy, because that's when the placental hormones kick in and they would try to destroy those RBCs of the fetus. Now, if mom doesn't get RhoGAM and she has an Rh positive baby, that baby could be born with hydrops fetalis, severe pulmonary edema, so it's pretty serious, okay? Treatment, depending on the severity of it, which is pretty severe in this case, phototherapy, exchange transfusions, if the baby is going to even survive. But the prevention is key, and prenatal care is key by the use of RhoGAM. And we'll talk about more about this in class. The immune system. So one of our goals that we talked about in the beginning was eliminating the risk of infection. So one of the big things is that white blood cells are slow travelers, and the immune system is still kind of immature. So it cannot localize infection. Therefore, generalized sepsis is more common more often so with the at-risk baby. So a premature baby, or babies that are born compromised to begin with, okay? So we have different IgG, okay? So IgG crosses the placenta and gives that temporary passive immunity to the bacteria or the virus, to the ones that the mother already has immunity to. Okay, IgM doesn't cross the placenta but starts to give the baby immunity to a few days after birth due to exposure of the environment. And this takes about a year to get full immunity. IgA doesn't cross the placenta, but it's found in colostrum, it's found in tears, blood, it's saliva, and it also needs to be produced by the baby. So the breastfed baby has an advantage to this one, and babies have less respiratory and GI infections. Leukocytes are immature and leave the baby vulnerable to infection. Okay, lymphocytes in the baby are a type of leukocytes that are responsible for antibody protection. So if they're repeatedly exposed to a pathogen, they will kill it. But because newborns are not born with this is delayed again, making them more vulnerable. So again, your premature baby, again, who is more at risk for everything, we have to be careful. So again, what do you think is the number one thing that we can do? Hand washing. Hand washing is vital with this population, especially with the at-risk baby. Infections are one of the leading causes of death and illness in neonates. Keep babies away from large crowds and gatherings, or stay away from anyone ill. So again, I know everyone wants to share their baby, but basically you should kind of keep them away. And one of the big things about this too is that babies won't have a fever usually. Now they will. I'm not saying that they're not. But one of the things that you need to look at is poor tone, poor activity, poor feeding, and kind of hypothermic. So that is where a baby can get sick very quickly and get that generalized sepsis. Okay. Again, you want to look for poor tone, unstable temps, poor feet, lethargy. One thing that I didn't mention are the most concerning. Now, getting into the physical assessment, so I'm kind of not doing like the head to toe, but we're going to be in the like the skin. So you're going to be looking at babies that have vernix, which is that cheesy like substance that actually is protects that baby in utero. And there's lanugo, which is that fine downy hair, milia, which looks like small little whiteheads, acrocyanosis we talked about, Mongolian spots, erythema toxicum, nevi simplex, and nevi flammis we'll talk about in class. One of the thing about the reproductive system too is when you're doing a physical assessment, you need to make sure to discuss the differences that you want to make sure that when you're assessing it, that you look at the differences between a term, a preterm, and a postterm, especially when we're looking at their genitalia. So, for example, in breast, most babies are going to have breasts, and sometimes because of mother's hormones, may secrete that almost looks like breast milk, and they call it witch's milk, and basically that's just a discharge that comes in from mom's hormones. Okay, female genitalia, like for labia majora for a term baby, covers the whole vaginal orifice. But if a baby is premature, the labia minora actually and the vaginal orifice is exposed, so it's more prominent than the labia majora. Boys, like preterm, they may not have no rugae on their scrotum. The testes may not have descended. But so there's a little bit different. So make sure you look at some of the pictures in your books, okay? In your book about some of the differences that you may see between term and post-term and preterm. So are tremors normal? What could cause tremors? What are normal reflexes? Tremors are common and can occur with crying and agitation. They could be jittery due to hypoglycemia. So you need to know mom's history. Okay, so if the baby's small, if the mom's diabetic, these are some of the issues too that you might want to look at. What do you remember about thermoregulation and glucose consumption? So again, you want to make sure that your baby's temperature is okay. Most tremors stop by about the age of 1 month. Reflexes are normal, and some are forever, and some are limited to weeks or months after birth. So that is it about the systems, and we'll talk soon.